Hi, everybody, and welcome to Module 3. Again, this will be a brief video going over some of the concepts discussed in the Roadmap to Better Health, and then touching on some of the coincident topics that have been raised in the assigned chapters in Being Mortal over the course of this module. So I'm going to share my screen and jump right into the PowerPoint here. So one of the sort of basic concepts is the whole notion of a roadmap to better health. And what does that really mean? There are ways, that healthcare delivery certainly obviously is a component of how we have improved health of the citizens in our society. But healthcare delivery is really only a minor determinant of overall health. Individual behavior, obviously, on a day-to-day, moment-to-moment basis, is far more important than the brief interactions most of us usually have, very sporadically and intermittently, with our healthcare providers. And that's even if someone conscientiously goes for their checkup every 6 months. You're spending 20 minutes or half an hour with somebody every 6 months. Obviously, what you do in between those times is far more important, right? And that doesn't mean that those appointments don't have value and that healthcare providers or healthcare practitioners don't have a big responsibility to help guide individuals toward healthier lifestyles. But obviously, what we do individually is a big part of that, and we have to take responsibility for our health, and we have to try to educate people that just going to the doctor every 6 months, if what you do in between is unhealthy, is not going to keep you healthy, right? And this is just some obvious things. Walk when you can instead of riding or taking some other passive means of transportation. Get physical activity, and we'll talk about how much in a little bit. But there are, we can actually measure objectively. What are some goals that we should all aspire to in terms of physical activity. Bring your lunch to work. Don't eat fast food. Try to take vacations. Right, mental health and spiritual health are important corollaries to physical health. And again, remove negativity from your life, and read more. Reading is a gateway to knowledge, right? And many of us read now in the kind of the way our culture has become. We get a lot of our reading and our input from the computer, and I'm guilty of that too, especially during the pandemic when I'm working on the computer. That I don't drag myself away from the computer screen as often as I should. But whether you read on your computer, on your iPad, on your Kindle, on your phone, or whether you're like me and you kind of dig the whole feel of an old paperback book in your hand, reading is knowledge, right? And knowledge is what protects us from ignorance and enlightens us in terms of how we can improve both our own lives and the lives of others, and gives us insight and experiences into how other people view the world, right? So that's really important. There's this sort of basic notion that we all actually know what healthy is, right? I mean, I don't think in this day and age anybody smokes because they think it's good for them. Although 50 years ago, 60 years ago, there used to be ads on television that would infer that smoking was actually good for you. And people know that eating healthier and exercising more is better on some level. But, do they really apply that in their lives? And you can, I think, legitimately ask, do some people actually believe that, right? And that is, I think there are individuals who don't really believe that exercise is important in terms of having a healthy lifestyle, that watching our diet is important. Some of us know it but don't do it anyway. I don't exercise probably as much as I should, although I try to make an effort to. And only recently, in probably the past 5 or 10 years, have I become much more aware of dietary choices and the impact that dietary choices have. And how can we get people to make better decisions, right? We can have things that we put in the environment that kind of nudge people in the right direction, walking paths, parks, things that make it easier to walk than to drive, right? Or things that make it easier or encourage people to be outside and enjoy themselves and do things that are active and enjoyable, right? We can have economic motivators, right? The so-called sin taxes. Not that these things are actually whatever sins, but the sort of colloquial term sin taxes. Things like taxing smoking and smoking paraphernalia, taxing alcohol, taxing cannabis now that many states are legalizing cannabis, taxing things that may not be so healthy, but that people engage in nonetheless, as a way to, number one, discourage them from doing it, but also as a way to generate revenue to channel toward other more productive things. Although that I don't want to get to the politics of it, but that can be controversial, right? And then there are educational nudges, all kinds of programs, especially in the schools, about healthier lifestyles, about eating and avoiding drugs and avoiding smoking and avoiding drunk driving and things like that, that are what we call educational nudges. In terms of physical activity, again, there are environmental ways that we can encourage that. Physical education in school, wellness programs at work, wellness incentives at work in terms of insurance premiums and things like that. Again, that sort of transitions into economical incentives, financial incentives for wellness, insurance premiums that are adjustable based on your evidence of being able to provide evidence of healthy lifestyle and physical activity, programs where a gym membership is one of the benefits of employment and so on. And then again, in academic curriculum, all the way from preschool up through college, right? There are ways that we can encourage and enlighten people as to the value of physical activity. When we look at modifiable risk factors in terms of disease, this is a really, sort of important concept, and it's there. There's multiple layers to this, both in terms of biology, psychology, sociology. We know that there are things that are what we call non-modifiable risk factors, and there are modifiable risk factors, and that interface between the two involves something that I've talked about in my Bio 202 course called epigenetics, right? Where we may be genetically predisposed to something, but unless we have certain environmental stimuli, that genetic predisposition may or may not be manifest. When we look at things that are not necessarily modifiable risk factors, our age, we all get older, our gender, that is not something generally considered. It is modifiable, but it's not necessarily modifiable in the context of risk factors for disease. Genetic factors, our genetic predisposition, our genes are what they are, and until we have gene therapy where we can change that, that's not going to change. And our genetic background, right? Race and ethnicity, all those things are not things that we can generally modify. We can modify things like blood pressure, right? We can get treatment for hypertension. We can modify risk factors like smoking. We can not smoke or stop smoking. Diabetes mellitus, right? And we can do type 1, we can at least treat it. Type 2, we can modify significantly by behavior, physical activity, and diet modification. Again, physical inactivity is something we can modify. Obesity, which is epidemic in the United States, we can modify through activity and diet management. And dyslipidemia, right? People that have high elevated levels of blood cholesterol, which is a significant risk factor for cardiovascular disease, which is one of the leading causes of death in human beings. And so all those things, they don't happen in a vacuum. There's an interface between them. And again, we can significantly impact our own wellness by number one, being aware of these things, and number two, modifying our behaviors to improve our overall wellness and our overall health. Smoking through massive, public education campaigns and through laws like not being able to smoke in restaurants and airplanes and in other public buildings. You guys probably aren't old enough to remember this. I can remember actually, traveling on an airplane. There was a smoking area. Like, you're in a tube, like 5 miles up in the sky, and someplace in that tube you could smoke, and that was like silly. So eventually smoking got banned on planes. Now smoking is banned in most public buildings, and you have to be a certain number of feet away from the entrance, and in restaurants and things like that. And so that those kinds of social pressures have significantly, and education of the public of why smoking is bad for you, have been significant in decreasing the incidence of smoking. Although every few years it starts to make a comeback. Again, we put huge taxes on them, some states more than others. A lot of media campaigns and changes to making the packaging less attractive to younger individuals. Vaping is sort of the new controversy about, is vaping the same as smoking? I think we've all probably had the experience of being someplace where somebody was vaping and thought it was fine. I'm not smoking, I'm vaping, and still like it's an unpleasant smell, or it's whatever. And so that will be the next frontier of law changes to deal with the inconvenience of vaping, in public spaces. And again, all of these things balance to some extent, personal rights versus the public good, and your right to smoke sort of ends where the secondhand smoke causes damage to me, right? And those things are important considerations. We look at what's bad about smoking. Again, those of you that have taken Bio-475 with me, and we've dissected human cadavers, we've seen in the differences between the cadavers, the incredible difference between the lungs of someone who's not a smoker versus the lungs of someone who is a smoker in terms of the damage that occurs. It results in both chronic and terminal illnesses in terms of COPD and emphysema and the significant increased risk of cancers, not just of the lungs, but other cancers of the air digestive tract, and even other kinds of cancers like breast cancer and so on. Second and third hand smoke is a big problem. One of the leading causes of asthma in children is having a smoker in their environment, right? And that is that's a big trigger for reactive airway disease or childhood asthma, is if someone's a smoker in the home environment, whether it's a parent or a grandparent or a caregiver or somebody that's coming into the child's environment and introducing second and what we call third hand smoke, which is contaminated clothing and rugs and things like that. And it is a tremendously avoidable cause of disease, and that's important to keep in mind. Another aspect of healthy lifestyle is obesity, right? And obesity is, this is a sort of a map of obesity, if you will, where we have countries listed here down the center, and you can see the incidence, the percent of population over the age of 15 that meets the criteria for obesity, usually by BMI over 30. And you can see here, some like Japan, very low, and the worst is the United States. Other countries that are really low: India, Indonesia, Costa Rica, pretty low, where we go on our study abroad program. Very different diet, even though a lot of the places we go sort of cater to tourists from other countries. The diet's very different, right? And it's not. There's a lot of things like rice and beans, other kinds of plant-based meals that are common and popular there, and a lot of fish, obviously, but not a lot of really heavy foods, a lot of really high carbohydrate foods. You can find those things if you look hard enough, but they're not what the general population eats there. And so you see these patterns among various countries where diet and lifestyle have a significant manifestation in terms of the fraction of the population that is obese, and all of the things then that go along with obesity, like type 2 diabetes and vascular disease and other sort of metabolic syndrome, right? The consequences of obesity. And again, some of those consequences we can discuss. Type 2 diabetes, which is insulin insensitivity, where the body becomes so accustomed to carbohydrates and insulin, it becomes desensitized to insulin, and that allows blood sugar to go up. Heart disease, in terms of individuals that have too much fat in their diet, particularly saturated fats, right? There's this notion that you have good fats and bad fats. Really, no fat is good for you. We need some fats in our diet, and those should be, again, the unsaturated fats. But a lot of that isn't good for you either. And so the notion that, I can have as much olive oil as I want is not really true. Those things, they get converted in some cases to other kinds of fats. And even in that, and even if those levels are high, they still can relate to some increased levels of LDL and increasing incidence of atherosclerotic disease. And so high blood pressure also associated with obesity, non-alcoholic fatty liver disease, where the hepatocytes begin to get replaced with adipocytes or fat cells. Osteoarthritis from the wear and tear, carrying around excess weight. I forget the exact formula, but my wife's younger brother is an orthopedic surgeon, and he was telling me that for every pound that weight gets multiplied by about a factor of almost 10 in terms of the force multiplication that occurs on your knees, for example. And so osteoarthritis of the knees, osteoarthritis of the hips, significantly associated as a comorbidity with obesity. Increased risk of stroke for the same reason as increased risk of heart disease. They're both manifestations, generally speaking, of atherosclerotic disease. And then other things like cancers of the breast, cancers of the colon, endometrial cancer, renal cancer, all of those things are associated with obesity to some extent or another. One of the really unfortunate things in our society is the increased incidence of childhood obesity. When I was in medical school, type 2 diabetes used to be called adult onset diabetes because you rarely saw it in children, and type 1 diabetes was usually first diagnosed in childhood, so it was called juvenile diabetes. And those terms aren't used anymore because of the incredible epidemic of obesity in children. We now see type 2 diabetes in children. And so, again, you see all these different medical complications or manifestations of childhood obesity. It's incredible the number of kids that are obese, that lead to lifelong health problems. It's really a problem in our society, and that we need to have much better education in terms of parental education, but also education of the children themselves in terms of combating childhood obesity. There's a lot of reasons for it. We have increase in our overall food calorie consumption. I am always trying to battle with my weight. It's a constant thing for me since I grew up as an athletic and relatively thin person, and then all of a sudden, once I reached about the age of 45, boom, overnight. I went from being able to eat whatever I wanted, whenever I wanted, to having to really be very careful. And that's not an easy adjustment to make at age 45 to 50. Trust me. You live your whole life one way for 45 years, and all of a sudden you have to change that. That's hard. And so, I'm pretty mindful of that. And I know, like, when my wife and I go out to eat, I'll look at a menu and I'll think, well, that looks really appetizing, but that's like 1,500 calories. Like, I won't be able to eat anything else until tomorrow at this time. And so, we also tend to consume more calories outside the home, even when we're eating meals at home. We go out, we go someplace and we get coffee, and I'll have a croissant with my coffee, or I'll have a scone with my coffee, or whatever. And then we have these huge portion sizes. The whole, if you haven't ever heard of it, the documentary Super Size Me with Michael Moore, who followed people with eating fast foods and these huge portions of fast food meals. The ubiquity and the popularness of sodas and other processed sugars and beverages is a big promoter, again, of hyperglycemia and increased glycemic index, and that leads to eventually insulin insensitivity. And kids that don't have good access to recreational facilities have I think it says on the slide 68, but it's a big increase in the chance that they are going to be obese. And there are that becomes an issue, not just sometimes of whether they have access to it, but it becomes very strongly correlated in terms of socioeconomic terms. Children that are from homes in lower socioeconomic brackets tend to have less access to those things, and they have, again, greater risk of obesity, and it becomes this perpetuating cycle of obesity, poor health, not being able to have a good job or hold a good job, and having, again, suffering the economic consequences of that. So those things are important. When we look at food that we make at home versus food that we get in restaurants, right? Restaurants tend to be very calorie dense foods, even places that we think of as, quote, healthier places, right? Very calorie dense kinds of meals. There's a particular, I don't want to mention any names or brand names or anything like that, but there's a particular place, where my family likes it's healthy food, but my family likes to order from there, but they send these like gigantic portions, when you order from them, and or when you go there, and that just is almost an American tradition. I think you don't see that nearly as much in other countries, where you go to a restaurant and then you order something, even if it's a healthy, if it's made of healthy materials, right? It's still this huge calorie dense meal. And so when you eat at home, not so much, right? You have a more balanced, first of all, you have a more balanced meal with appropriate balance between proteins, carbohydrates, and fats, with adequate amounts of fiber and so on. So you can have nutrient-dense foods that are not calorically dense, right? There's a difference between the two things. Again, the numbers here, we should always, for an average adult, aim just under 2,000 calories a day is a good goal. But again, you can easily reach that, in one meal. If you have a really sugary drink, this calorie dense, whether it's a, burrito or a burger or whatever, and a couple of sides, all of a sudden, you're there. You're close to 2,000 calories in one meal for the day, and that's not a good way to maintain our to get our caloric intake. And so it's important to keep that in mind. I think, we are all busy. You guys are busy. I'm busy. We all tend to lead busy lifestyles. It's not always easy. My wife and I are guilty of this. We'll both get home at night and neither of us will feel like cooking. And it's just easier to, call Uber Eats or run out to get something or run over to some place and have dinner. And again, when you do that, it's okay, but you have to be very mindful and conscientious about saying, okay, I'm going to have something, but I'm going to order something that is comparable to what I would normally have had if I was home in terms of both calories and nutrition. When we look at portion sizes, this is very well documented how our society has changed, right? So I can remember, again, I don't want to tell you exactly how old I am, but I can remember when I was a child going to fast food places where it was like a big treat after a Little League game. I'd get to go to a fast food place and get whatever crap I wanted for dinner, which again is not necessarily the best idea to reward children with crappy food, but I'll forgive my parents for that for now. But you look at the number of calories, right? There's a 120 calorie burger, 200 calorie fries, an 85 calorie drink. Now, the burger is, if it's a healthy one, it's 310 burgers. Most of the time, you get a burger someplace, it's more like 500 or 600 calories. And same with the French fries. They're going to be, 500 to 700 calories, depending on what you put on them. And this huge sugary drink. And so, you're looking at, roughly a, 500% increase in the caloric intake. And that is, that is a tremendous amount of difference between, what people get when they go out for a meal versus what we actually need when we go out for a meal, right? Again, if you're trying to keep your calories under 2,000 calories a day, do a little experiment with yourself. If you're not really, I know some of you are really into nutrition, but if you're not, pay attention to it for a week. Pay attention to what each of your meals is in terms of total calories, portion of calories from protein, portion of carbohydrates, portion from fat, and keep an eye on that. It's really it's eye opening. I again, because of my family history, I am very mindful of watching my fat intake and monitoring my own cholesterol. And I try to follow the American Heart Association guidelines. And it's really hard because American Heart Association says you should only have, 25 or 30% of your diet should come from fats, and even less of that should come from saturated fats. And it's like, you have one bowl of gelato and you're done with your saturated fats for the day, right? So you have to, that our gastronomic culture, right? What we eat, what we're exposed to when we're out in public, does not promote what is ideally a healthy lifestyle in terms of both the amount of calories that we eat and the content of what those calories are made up of. This is some great dietary advice. I heard this with a world-renowned nutritionist from Harvard. I think it's the best dietary advice I've ever heard. 7 simple words: eat food, not too much, mostly plants. And then this is a cookbook that my children gave me. It's the How Not to Die cookbook, but it is a plant-based cookbook, and so it's there's no meat recipes in it. Although I'm not strictly vegan, I try to avoid meat as much as I can. But the notion that the less fat we have in our diet, the better it is in terms of atherosclerotic disease. And then there are some, there's omega-3s, which we need for vascular endothelial health, but that's a very small amount of fat, and it comes from those come from very specific sources. And so I recommend this book highly. If you're interested in nutrition, you're welcome to email me if you don't want to feel like scanning all the way back through the video to get it after I leave this slide. I'm happy to recommend it. It's a great book, and there's some really good recipes in it. I learned how to make like ice cream from frozen bananas, and my wife and I happen to really like chicken salad, and we learned how to make chicken salad from chickpeas instead of from chicken salad. So it's a fun book, and there's some really good stuff in it. physical inactivity, a big part of why we have such a problem with obesity in our culture. Less than half of Americans meet the recommended guidelines for activity and strength activities, for about 20%. That we don't always, a lot of schools have dropped PE for financial reasons. There's especially with changes that have occurred in our society, with people working from home and other aspects of how our culture has changed, we don't get as much physical activity as a culture as we used to. And again, in other countries that's not necessarily true. And in other countries, people think nothing of walking a mile to go do something, right? Here in the United States, it's a big deal, right? Nobody walks a mile just to go get something from the store. And so, that's a really interesting contrast. Again, in our study abroad program, when I'm in, I always monitor my steps, on my phone. I try to get 10,000 steps a day. When I'm in Costa Rica, it's like nothing. It's just existing. I get like 13 or 14,000 steps a day, because that's just how things work in that particular, the place where we go. And at home, I have to make a conscious effort. I have to take a 3,000 or 3,500 step walk at night to make sure that I get to my 10,000 by the end of the day. And so a lot of that are just the daily, the pressures of our daily routines, whether it's school or work or whatever. It's not always easy to get the amount of physical activity that we should. Speaking of what we should get, we should get somewhere around 150 minutes of anything that gets our heart beating faster, right? So riding a bike, swimming, walking, and people that are wheelchair bound, getting out and moving in their wheelchair, gardening, anything that gets us out. And where, so it's easy, 150 divided by 7 is roughly 20 minutes a day, right? A little over 20 minutes a day, where we should get out and do something that really gets our heart rate up. I try to do it with walking, and it's just off the camera here, but my stationary bike. Those are things that I do to try to make sure I get at least 25 or 30 minutes a day of exercise that gets my heart rate going. And then at least 2 days a week, we should do some sort of muscle strengthening training, weightlifting, even something really simple like just getting up in the morning and doing push-ups and doing sit-ups, right? Or doing some squats or something like that. Lunges, anything that helps with strengthening various muscle groups, right? And that's important. And we should do that at least 2 or 3 days a week. And then kids, if you're a sports fan, some of the major sports leagues, like baseball and football, basketball, have prompted these various active 60, various things where you try to encourage children where they should be doing something 60 minutes a day that involves some sort of physical activity. So we look at how does that lead to a better life, right? And again, when we think of the concept that and unfortunately many people think about health this way, where we're all willing to, or many of us are willing to, sort of put the responsibility for our health in the hands of healthcare professionals who, they should be valued for their knowledge and their technical prowess. But they're not, experts on understanding human needs. And it's pretty clear that that's a failed experiment. We need to be responsible. We need to teach people to be responsible for their own well-being and their own wellness 24/7, right? That's when we live. We don't just get a certificate of wellness because for 5 minutes or 10 minutes or 20 minutes or whatever, every 6 months we go to the doctor and they listen to our heart and lungs and say, okay, everything sounds good. That's not what wellness really is, right? And when we talk about wellness, we talk about both quantity and quality. If you look at just in the state of Arizona, a tremendous number of people live with a lower quality of life because of chronic disease. So then you start talking about, well, what does quality of life mean, and what does that mean in terms of both how long we live, right? And there have been all kinds of studies that show that patients, for example, who enter hospice and stop medical care live as long or longer than people who undergo heroic, risky, last-ditch efforts to try to cure a disease which is at this point not curable. Does increasing or changing our modifiable behavior risk factors lead to a better quality of life and a better end-of-life experience, if there can be any such thing as the quality of our end-of-life experience? And I think there is. I think you can have a higher quality end-of-life experience than having an experience that is unnatural and dragged out and with hopeless and invasive medical interventions. Those are obviously there are huge, personal factors to consider there in terms of what somebody believes and what somebody wants and what somebody hopes for, right? But those have to be tempered by the reality of whether or not we're dealing with something that's treatable. And again, you look at quantity versus quality in terms of lifestyle. Ideally, we want to have a high quality lifestyle. We want to have a good quality of life as we go through life, and we hope that everybody is able to live what we call a long and healthy life. Right? It sounds like a simple statement, but at the end of the day, that's what we want: a long and healthy life for everybody. When we look at things like your bucket list, I think a bucket list is a cool thing to have. All the things that we would like to do or accomplish, even if you don't accomplish some of them. What would you want to do or see or experience before you die? I hope most people have priorities beyond just prolonging their lives, right? It's your quality of life and your experiences while you're alive that matter, and how you live matters, I think, tremendously. These are some things, some little snapshots of things from my bucket list that I've actually got to do. This is a sunrise from the top of the Haleakala volcano in Hawaii, in the island of Maui. This was taken paddleboarding with my kids in Costa Rica. This was when I was on sabbatical, having lunch at Victoria Peak, which is a peak that overlooks the city of Hong Kong. That was quite a while ago, before some of the recent political changes and turmoil that have happened in Hong Kong. And this is from a trip I took with my brother to Key West, and the southernmost point. This huge sort of monument is 90 miles across the water from Havana, Cuba. So there's some fun things that I got to do that, again, I think those are all things that, when we look back at our lives and we think of what are the things I've accomplished, what are the things I've enjoyed, I think, being able to review some of the things that you were able to do, that you read about in a book and thought, well, I'd like to do that, or you saw it on, some documentary or something. Those are neat things that make our quality of life unique to us, but special in some way. When we talk about death and dying, it's not a pleasant topic to talk about in social conversation. We generally don't bring it up a lot, right? I think many people in our lives, all of us at some point experience the loss of someone close to us. Is it something that happened slowly or unexpectedly? Were there advanced directives? I think I mentioned in my previous video about one of my grandparents and having had advanced directives. And these are things to think about, and they're kind of like writing your will, right? It's a creepy feeling, like writing your will. I remember the first time my wife and I did it, I was like, this is weird, and I'm not into doing this. But they're all things that are part of life, right? And we have to deal with those things. And advanced directives are a really important part of that, in terms of what we, being able to express when we're healthy and of sound mind, and able to express ourselves coherently to others. Being able to express, what's important to us, right? And so, we think about things like advanced directives. They are a legal document that is, witnessed, notarized, and it's our expression of what we want done. Do I want to be on a ventilator? How long do I want to be kept on a ventilator? Do I want to have a feeding tube, or do I not want? Am I not willing to go that far to have a feeding tube? Do I want to be resuscitated if I have a cardiac arrest or some other thing? And that's those are things that are not pleasant to think about, but they are things that can make the difference between whether you are stuck in a situation where healthcare providers are obligated to not just let you die, right? Or physician-assisted suicide, versus something you wouldn't have wanted, right? Like I might say, I don't want to be on a ventilator for more than a week, right? And because I know that statistically speaking, if you're on a ventilator for a week, once you get to a certain age, it's pretty unlikely you're ever going to get off it, at least from a perspective of data analysis. And so you might decide, okay, once I get to be a certain age, I'm not willing to be on a ventilator for more than a certain amount of time. Or, once I get to be a certain age, I'm not willing to be resuscitated anymore. I don't want to be resuscitated and, be kept alive in a bed with, major cognitive deficits because, before I got resuscitated, I had damage to my own cerebral cortex. And so those are things to think about and to make informed decisions about, and to express your thoughts about those things before those things happen, so that you have some input, some autonomy into how you are treated when you can no longer express yourself. We think about hospice. Again, hospice, I think most people think of as something, you just do for people where their condition is hopeless, that it's about giving up and surrendering. And it's not necessarily. It's about making the most of life by living as fully and as comfortably as you can, and not not engaging in therapies or treatments that have very low probability of being successful and have a very high likelihood of significantly impairing someone's quality of life. For example, taking chemotherapy drugs that make someone feel just awful and sick and horrible, 24 hours a day, and have very low probability of curing their disease, versus saying, okay, I'm not going to have any more treatment. I'm just going to live my life as comfortably as I can and spend as much time as I can with the people I love and care about, and accept that that this is my path. And again, those are very personal decisions, but I think it's important as future healthcare providers that we all be mindful that there's this myth that hospice is somehow giving up, and it's really not. Hospice is about acknowledging reality and allowing people to end their lives comfortably and with dignity. And I think that's critically important for people to have that opportunity. Now, and again, it's not for everybody. Some other people might say, I'm willing to feel like crap 24 hours a day if there's even the tiniest chance that I might get better. And again, those are those are individual decisions, and I know people that have made both decisions. And, I've seen people who were really uncomfortable, in a lot of pain, and the exotic therapies that they underwent didn't help them. And I've seen other people who said, you know what, I'm not going to do that. I just want to be comfortable. I just want to be in my own house. I want to be around the people I care about. And, you know, they opted not to have, you know, potential life-saving therapy. And so, again, those are very individual decisions that people should have. People should be empowered to make for themselves. Again, the last thing is, you know, this notion of how to die. Is there a right or a wrong way? Of course not. That's a very personal thing. There's a couple quotes that I have here. You know, one is that death is not the opposite of life, but it's a natural part of life. And then one of my favorite authors, Mark Twain, puts it in a very sort of, you know, Mark Twain kind of way of looking at it. Says, you know, I don't fear death. I've been dead for billions of years before I was born and didn't suffer the slightest inconvenience from it. So, you know, I think those are both healthy ways of looking at which is a natural phenomenon, right? When I was looking for quotes to put on the slides, you know, I saw all kinds of things, you know, that, and again, it is a part of life. You know, whether we like to think about that or not, we are mortal, and as such, our mortality again is what defines us, and the end of our life is very much a natural part of our life as the beginning and the middle and every other part of it. And you know, we I think need to all be more mindful of what our views and our wishes are, and to be able to discuss those things again, even though it's not polite, you know, public conversation or social conversation. These are hard conversations to have, and none of us like to think about it. You know, I've had these conversations with my parents. I always, you know, it's like, I don't want to talk about this, and you know, I have to have the same conversations with my own children. It's the same thing. They don't want to talk about it, and you know, I get that. None of us, we all have, you know, denial is healthy in some ways, but you know, there are things that we need to be, you know, things that we need to be mindful of and aware of and acknowledge as part of our natural life cycle. And again, I think the medical establishment puts a lot of pressure on people to live as long as possible, regardless of the quality of our lives, right? And I've heard doctors say to patients who did not want to have, you know, the risky chemotherapy with a very low chance of success, don't you want to live to see, you know, whatever? And to me, that's just a terrible thing to say to somebody, to try to make them feel guilty for wanting to be comfortable and have a high quality of life at the end of their life, as opposed to some risky kind of very low likelihood of a procedure or a therapy that has high risk and very low likelihood of being successful. Statistically speaking, most of the time when people have really aggressive therapy due to a disease which is, you know, quote, untreatable, they get a few weeks or a few more months compared to people who say, okay, I get it, this is not treatable and I'm not going to be treated. And so that is, you know, when you put it in context in the, you know, how much time difference it actually makes, it generally doesn't make all that much of a time difference. And again, those are important personal decisions, but it's important in order to empower people to make those decisions. They should have the information that they need to be able to make an informed decision. So that's what I have for you in Module 3. Again, I hope everything continues to go well for you in the course, and I look forward to seeing you in the Module 4 video. See you later.